presenting a new series Medically Verbal where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 7. Chief complaint. A 22-year-old female presents to the clinic with fatigue and weight gain. History of present illness. The patient reports feeling increasingly fatigued over the past 6 months despite getting adequate sleep. She has also noticed an unintentional weight gain of about 10 pounds during the same period. Additionally, she mentions feeling cold more often than usual and experiencing constipation. Her periods have become irregular with longer intervals between cycles. She doesn't have a significant past medical history, currently on no medications, doesn't smoke, drinks alcohol occasionally, and is a college student. Mother has hypothyroidism, father has hypertension. Physical examination shows BP 120 systolic, 80 diastolic, heart rate 60, respiratory rate 14 per minute, temperature 97.8 degree Fahrenheit, SpO2 98% on room air. Her skin is dry and she has brittle hair. She doesn't have any palpable goiter or thyroid nodules. Her rhythm is regular and does not present with murmurs. She is clear to auscultation bilaterally. Her abdomen is soft, non-tender, and the bowel sounds are present. Her extremities does not present with any edema. Initial differential diagnosis: hypothyroidism, polycystic ovary syndrome, depression, anemia, chronic fatigue syndrome. Based on this presentation, what do you think is the most likely diagnosis and what further investigations or management step would you consider? So this case is basically a mixture of, it feels like it's a mixture of two diseases. One is polycystic ovary syndrome and the other could be hypothyroidism. Why? Because irregular periods and weight gain indicate towards polycystic ovary syndrome. At the same time, fatigue, weight gain, feeling cold, dry skin, constipation are symptoms of hypothyroidism. Though the symptoms of hypothyroidism are more, the symptoms also strongly suggest of PCOS. So what are the investigations that we are going to run on her? We'll do blood test on her like TSH. So if she's suffering from hypothyroidism, her TSH levels are going to be elevated because they want the body to produce more of the thyroxine amount, which is not getting met with the body's need. Then her free T4 levels would be low, her free T3 levels should be low. So we'll evaluate that, and if the levels come out to be low, then it's hypothyroidism. At the same time, we'll check for thyroid antibodies, anti-thyroxide peroxidase, which is anti-TPO. So why are we checking thyroid peroxidase and what does it do exactly? Thyroid peroxidase adds iodine to the thyroglobulin. So it basically helps in the synthesis of T3 and T4. Now, if there is anti-thyroid peroxidase present in the blood, that means it is working against thyroid peroxidase, which leads to hyposecretion of thyroxine hormone. At the same time, we'll check for anti-thyroglobulin antibodies, because if there are, they'll be working against thyroglobulin, which would lead to a hyposecretion of thyroglobulin in the blood. This would help us in checking for autoimmune diseases like Hashimoto's thyroiditis. For the hormonal profile, we'll check her total and free testosterone level. So what happens is that when the person is suffering from PCOS, there is often an LH surge in a very disproportionate manner. When the LH surge is present frequently, and if, let's say, the insulin is also produced in a large amount, the ovaries tend to produce testosterone. We'll also check for her LH and FSH ratio. When it is greater than 2:1, it can suggest PCOS. we will also suggest for a prolactin test. Why a prolactin test? Because if there is hyperprolactinemia in the blood, that means there could be a pituitary tumor. To rule that out, we will check for the prolactin levels in the blood. Then at the same time, we would check for sex hormone binding globulin. This is low in PCOS. Why is it low? What happens is, when there is large secretion of insulin, then the liver tends to hyposecrete the sex hormone binding globulin. Now, what the sex hormone binding globulin does, it actually helps in binding of the testosterone, whatever that is produced in female's body. Now, if that testosterone binding does not occur, there is high level of testosterone seen in the woman's body. We will check for a metabolic panel. We'll check her glucose and insulin levels so that we can see whether she is facing any sort of insulin resistance, because it is associated with PCOS. We'll check for a lipid profile. Now, in hypothyroidism and PCOS, we often see dyslipidemia. Why? Because whenever the level of androgen increases in body, the level of triglycerides also increase. Triglycerides, at the same time, the level of LDL also increase. Now, an elevated level of triglycerides, LDL, and a decreased level of HDL is what is known as dyslipidemia. We'll do an imaging test by performing a thyroid ultrasound so that we could see the thyroid gland and to check whether there are any abnormalities or any nodules or any goiter present. They weren't palpable, but something might come out in the ultrasound itself. We'll check for a pelvic ultrasound, of course, to see the presence of ovarian cyst, which is a very, very important feature of PCOS. Now, once we figure out what it is, we'll manage it out accordingly. For hypoparathyroidism, we'll give her levothyroxine to replace the deficient thyroid hormone, and we'll ask her to follow up regularly so that according to her symptoms, we could manage out her dose. For PCOS, we would ask her to reduce her weight, go through exercises and improve her symptoms. At the same time, to maintain out her. For the medications, we will ask her to take oral contraceptives so that she could regulate her menstrual cycles and so that she could reduce androgen levels. Now, this is an optional thing. If she is positive for insulin resistance, we would provide her with metformin so that we could manage out her impaired glucose intolerance. Okay, and we would provide her with anti-androgens because she has a high level of testosterone in her blood. We would have to provide her with anti-androgens, otherwise there could be symptoms like hirsutism. What is hirsutism? It is unwanted facial chest hair. So we could give her spironolactone, and of course, the patient suffering from PCOS often has difficulty in conceiving child. So we would provide her with a fertility treatment plan so that she could go over for a pregnancy. We could give her ovulation induction agents like letrozole. For supportive care, we would ask her to go with a balanced diet and have a low glycemic index food. And at the same time, we'll screen for our mental health, because a lot of patients suffering from PCOS often start going into depression because of the changes that go through their body. They are not able to really build a pace with that. And also, we'll do a regular monitoring for her. Every 6 to 12 weeks, we'll do a thyroid function test, and then less frequently. And we will check for her hormonal profile and metabolic parameters so that we could see that any abnormalities develop over time, so that we could manage out that syndrome. We could manage out any metabolic syndrome regarding the abnormalities. Hope you guys like the case study of today. Make sure to take a screenshot to sum it up, or you can come back whenever you want. Please do not take this as a substitute for medical advice, because it is not. It is just for understanding purposes and to learn how to diagnose our diseases. Thanks for watching. Corrections or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.